So today, we're going to dig into a hidden danger that lurks between two of the most common prescriptions out there, a painkiller that millions of people use and the antidepressants that are just as widespread. What happens when these two meet? Well, the answer is pretty surprising.
First, let's just get a sense of the scale we're talking about. This number, over 16 million, that's how many times the painkiller Tramadol was prescribed in the US in a single year. It is incredibly popular. But what's really fascinating is that behind its popularity, there's a complexity that even a lot of doctors might not fully recognize.
And that leads us to the big question here. What actually happens when these two very common worlds collide? As it turns out, there's a significant risk that seems to be flying completely under the radar.
To really understand this risk, we have to start with Tramadol's secret. You see, most people, and even many clinicians, think of it as just another opioid. But that's only half the story.
Okay, here's where it gets really interesting. Tramadol has this unique dual-action mechanism. On one hand, yes, it acts like a typical opioid. It blocks pain signals in your brain. But it also does something else, something totally different. It boosts levels of serotonin and norepinephrine. And that is exactly what a whole class of antidepressants does. This dual action is the key to this entire story. So since Tramadol is already boosting serotonin, a big problem can pop up when it's mixed with other drugs that also boost serotonin, like so many common antidepressants. All of a sudden, you can wind up with way too much of a good thing. And that can lead to a condition called serotonin syndrome. It's essentially a toxic state caused by a complete serotonin overload in the brain. Now, it can be mild, but in severe cases, it can absolutely be life-threatening. And it's one of those things that's way, way easier to prevent than it is to treat. And the symptoms are no joke. We're talking about everything from mental changes like confusion and agitation to scary physical symptoms like a racing heart and muscle twitching. This isn't just a minor side effect. It's a very serious medical event. So this known risk got a group of researchers in the Netherlands thinking, and they started asking a really critical question. If this drug interaction is so potentially dangerous, are the people actually prescribing these drugs aware of it? The researchers really wanted to know two things. First, do doctors even know about this risk? And second, if they do know, does that knowledge actually change how they prescribe the drug in the real world? And their method for finding this out was really clever. First, they surveyed doctors using hypothetical patient scenarios to see if they would avoid prescribing Tramadol to someone on an antidepressant. Then they went and analyzed the hospital's actual pharmacy records to compare what doctors said they knew with what they actually did. And what they found, well, it revealed a pretty major disconnect between what doctors were aware of and how they acted in their day-to-day practice. The first result was just shocking. Only about a quarter of the doctors they surveyed were even aware of this potential drug interaction. That means the vast majority, we're talking 70 to 80%, had this serious clinical blind spot. Okay, so awareness was clearly very, very low. But, maybe doctors were avoiding this drug combination for other reasons we don't know about, right? Well, that's where the pharmacy data comes in to tell the real story. And this is the real punchline. When the researchers looked at thousands of actual hospital prescriptions, they found almost no difference. Patients who were already taking antidepressants were given Tramadol at pretty much the exact same rate as patients who weren't. The risk, whether it was known or not, seems to have zero impact on prescribing habits at all. All right, so let's just take a step back. We've established a clear, often overlooked risk. This naturally brings up an even bigger question. I mean, to accept a risk like this, you would expect the reward, the drug's actual benefit, to be crystal clear. But is it? Let's really zero in on one of its key uses, treating chronic neuropathic pain, which is basically pain from nerve damage. Now, given the risks we've just talked about, you would hope the evidence for its effectiveness here is absolutely rock solid. To find out, we have to turn to the highest standard of medical evidence there is, a Cochrane review. So a major 2017 Cochrane review looked at all the high-quality trials on Tramadol for this specific type of pain, and honestly, the findings were pretty sobering. The studies they could even find were small, often inadequate, and had a high risk of bias. Their conclusion on the overall quality of the evidence, they rated it as low or even very low. And the review authors did not mince words. They concluded, and I'm quoting them directly here, This research does not provide a reliable indication of the likely effect, and the likelihood is very high that the effect will be substantially different from the estimate. I mean, wow, that is a powerful statement about just how uncertain the drug's benefit really is.
So the key takeaway from the absolute best evidence we have is this. For a drug with a real, though underappreciated risk, its benefit for one of its key uses is resting on a surprisingly shaky foundation of evidence.
And all of this leaves us with a final and I think really crucial question. When a drug's risks are hidden in plain sight and its benefits are more debated than they are certain, how can we really weigh that risk versus reward to make sure that patient safety always comes first?